Hello and welcome to this class on palliative care. I'm Professor Dr. Anthony Cummins, and this is from the Department of Family Medicine at RCSI Perdana, University of Medicine and Health Sciences. These are the learning outcomes for this class. You should be able to define what palliative care is. You should outline the required professional competencies of doctors providing palliative care. You should be able to describe the management of common symptoms in palliative care, for example, pain, dyspnoea, anorexia, nausea, and constipation. You should be able to conduct an assessment of a patient with a life-limiting condition, and you will be asked to deliver a case presentation of a palliative care patient in week 7 of your family medicine posting. And finally, you should be able to outline the challenges and complexities of palliative care delivery in Malaysia. What is palliative care? Well, the World Health Organization defined it as an approach to healthcare delivery that improves the quality of life of patients and their families facing problems associated with life-limiting illness. And this can be achieved through the prevention and relief of suffering by means of early identification and assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So it's quite a complex definition here. So what is it and what does it work? Well, the palliative care approach is aimed to promote physical and psychosocial well-being in patients with life-limiting conditions. But it shouldn't be seen purely as the work of palliative care doctors, but actually these should be skills and professional attributes that would be integral to all clinical practice wherever you end up working. Whether you're a surgeon or a physician or a palliative care physician, you should know about and be able to provide a palliative approach to your patients where appropriate. Is it a good thing? Does it work? The evidence is absolute. In fact, in ethically conducted randomized controlled trials in patients with poor prognosis lung cancer, the palliative approach versus the traditional or standard approach gives a much better quality of life and longer survival. So what are these life-limiting conditions? There's a myth that abounds that palliative care is all about the elderly and it's all about cancer, and particularly terminal cancer. This is not the case. There are many conditions which are life-limiting, and these are just some of them here, for which a palliative approach is preferable than an attempted curative approach. For example, class 3 or 4 heart failure or respiratory failure due to COPD gold stage 3 or 4, pulmonary fibrosis, progressive motor neuron disease, end-stage dementia, cirrhosis of the liver plus or minus liver failure, and end-stage renal disease, and there may be others as well. Multiple sclerosis is another example. Palliative care in Malaysia is relatively new and was begun around 1995. There are two main service provisions, one based in Hospital Selayang, which provides inpatient care day services and clinics, and one with, in addition, community-based services from Hospis Malaysia in Shiraz, and this is a service to which you will be attached. This is the symbol of Hospis Malaysia, the pallium. What does this symbol signify to you? What comes to mind when you see it? We can discuss these in class. This is Hospis Malaysia's website, and here also, and this is their Twitter address. Palliative care isn't just about cancer, and it isn't just about elderly patients. So here's Nami, who's 14, suffers from spinal muscular atrophy, and has been attending palliative care at Hospis Malaysia for the last 4 years. In terms of quality of life, Nami has achieved lots of things in the last 4 years, such as being a scout, an avid chess player who won a gold medal for Malaysia at the 2013 Asian Youth Paralympic Games held in KL. He's often even taught himself how to play blindfolded shortly after witnessing a blind chess game. But he's been regularly receiving palliative care for his spinal muscular atrophy. Palliative care in Malaysia is different from how it is conducted in Ireland and in Britain, in that the GPs have a much bigger role there than they do here. In Malaysia, the GPs have little or no role in palliative care. In Ireland and England, most of the generalist role is performed by GPs. And then with an interaction with specialist palliative care services, the equivalent of Hospis Malaysia or Hospital Silayang in Ireland and the UK, and with a lot of interplay between the two, and inter-agency referral and so forth. Good communication is central to all of this. This is a link to a series of videos from the Irish Association of Palliative Care. These are worth looking at in your own time. Apologies, I seem to have gone right into that. Okay, back out. This is Hospis Malaysia in Cheras, and just an outline of the different services they provide, as well as providing individual patient care. They also run workshops for caregivers. They workshops for allied professionals in healthcare, nurses and others. They also provide nursing training and various workshops on ethical challenges, communication skills, and so on, and also developing pediatric palliative care in Malaysia. It's a domiciliary service, so when you attend there, you will go to the Cheras base at 8 a.m. on your first day, and then you will go with the nurses after their handover meeting to individual patients' homes. The domiciliary service is and there's an initial assessment, and then once that's done, the staff will prioritize the problems with the patient and family, propose a plan of management, give medication if that's appropriate, recommend equipment if need be, and involve other people such as occupational therapists and so on. They also have a 24-hour on-call service for patients and families. There are several professional competencies that are essential to the provision of palliative care. That's a clear understanding, firstly, of the principles of palliative care, the underpinning of all of this by good communication, clearly aiming to optimize comfort and quality of life. Care planning is very important, and collaborating with others. Preempting and managing loss, grief, and bereavement are essential, and is overall professional practice, and also managing ethical challenges that arise within the context of palliative care. Care planning is very important, particularly around transitions of care. These are times when patients are transferred from hospital to hospice, from hospice to home, and so on. And this is where often things may be missed, information may not be transferred, and it's really important to have a checklist manifesto approach so that nothing is forgotten. It's very important to establish goals of care, like how new symptoms will be managed, recognition of potentially reversible causes of deterioration. So, for example, a patient with lung cancer develops worsening breathlessness. Clinical examination important here to outrule a pleural effusion, and the finding of a pleural effusion means, well, this can be aspirated and this will improve the symptom of breathlessness. Sometimes there is an inevitable deterioration in the patient, and with experience, physicians come to differentiate this from a reversible cause of deterioration. Essential throughout is shared information, good communication, and collaborative practice. Advanced care planning is important for the future, particularly if somebody should deteriorate further and at a time when they may not have the capacity to make a decision for themselves. It is not legally binding in Malaysia yet, nor in Ireland, although legislation is underway and in both countries for this to become law. At the moment it isn't. It is in the UK and also in the US. Ethical issues arise commonly in palliative care, particularly in relation to communication. For example, does the doctor communicate with the patient only, or the patient and family, or the family only and not the patient? How does the doctor manage bad news? A worsening of the prognosis, for example, or giving the initial diagnosis. What about advanced care planning? What about requests for euthanasia or assisted suicide, which are not unusual? What about the challenge of withholding and withdrawing treatment at end of life? And what of the issues surrounding artificial nutrition and hydration? The aim throughout should be to aid comfort and improve quality of life, and this is done through management of symptoms, to recognize deterioration, reverse what can be reversed, and recognize that as the situation advances, you may need to change your focus of care and treatment goals. For all symptoms, in general, it's best to, where possible, diagnose the cause and treat it, rather than just treating the symptom. So you need to look at what's been underlying this, what's precipitating it, what's relieving it, and any other associated factors. You also need to bear in mind the meaning of the symptom for the patient and the family. To you, the doctor, it may just be a pleural effusion in somebody with lung cancer, and that would not be unusual in your view. In the patient's and family's view, however, it may suggest this deterioration heralds imminent death, but they may not voice this. So you need to be aware that this might be how they feel and perhaps explore that with them. You need to examine the patient to look for preventable or treatable causes of deterioration, such as the example I gave earlier, pleural effusion in somebody with breathlessness and a background of lung cancer. You need to make sure also that to avoid you need to make sure that symptoms are managed regularly rather than as a PRN. So a good example is pain management. Patients should be instituted on, when it's appropriate, regular twice daily morphine, with morphine available also as discretionary doses for breakthrough pain. These should be given in conjunction with laxatives, because it's an absolute given that if you take morphine even after a few days, you'll become constipated. So you shouldn't wait for that to develop. You should give laxatives whenever you prescribe morphine. You should also prescribe laxatives. If the patient can take medication by mouth, please give it by mouth. Other routes are not as reliable, and particularly intramuscular route is often very painful, especially in end-of-life patients with cachexia and poor muscle bulk. We also have to give somebody continuous subcutaneous infusion or syringe driver for pain relief as they near the end of their lives. They may not be able to take oral medication, be unable to swallow, they may be drowsy, they may have recurrent vomiting, etc. So CSCI should be considered. Also, transdermal opioids are available, like fentanyl and other patches. These are a range of symptoms that are common in palliative care. It's important to identify these and identify if there are any reversible causes of them. You need to look at looking at pain, the causes of pain. Is this from the primary illness? Is it a complication? Is it a complication of treatment? Is it something else? Is it a concurrent acute illness? And use as your guide the World Health Organization pain management or pain relief ladder, which is steps 1, 2, and 3. Step 1 is a non-opioid, plus or minus an adjuvant. Step 2 is a weak opioid, plus or minus a non-opioid, plus or minus an adjuvant also. And step 3 is a strong opioid, which would be like morphine or the morphine derivatives, plus or minus non-opioid or adjuvant. We'll go through these in some detail now. So a non-opioid would be the likes of paracetamol in a dose usually of 1 gram, that's 2 500 milligram tablets 4 times daily, and a non-steroidal example would be ibuprofen, 400 milligrams up to 4 times daily. A weak opioid would be the likes of a paracetamol codeine combination such as Solpadol, again given in a total daily dose of 240 milligrams daily, and a tramadol, again same dose, 2 tablets up to 4 times daily. The strong opioids range from morphine to buprenorphine. You need to be aware that oxycodone is twice as strong as morphine, so it's important not to make errors in dose calculation if changing from morphine to oxycodone, and hydromorphone is actually 5 times more potent. So again, beware when making drug switches. Fentanyl is a transdermal, transmucosal, strong opioid, and buprenorphine can be used as a patch or as a sublingual tablet. This is a table showing comparative doses. So starting off with 240 milligrams total daily dose of codeine. These are the various, and similarly 200 milligrams of tramadol. These are the equivalent doses in morphine, OxyContin, oxycodone, Palladone, hydromorph, butrans, Transtec, fentanyl, and another one called alifentanil. It's a useful table to consult when you're not sure if the patient is receiving the correct dose. So let's look at an example. This is a patient who has uncontrolled pain and is already on salperidol at a total daily dose of 240 milligrams of codeine per day. If I just go back, and you'll see the equivalent dose of long-acting morphine, if for that of 240 milligrams is 20 milligrams, which is 10 milligrams twice daily. So you switch this patient to morphine sulfate 10 milligrams BD. This is the long-acting form, sometimes called morphine sulfate continuous or controlled release. And then you add for breakthrough pain some short-acting oral solution called Oramorph. It can also be available as a tablet, but usually people prefer it as liquid. Oramorph, and the dose calculation is conventionally 1/6 of the total daily dose. So if the total daily dose is 20 milligrams, that's 10 BD, then 1/6 of that is approximately 3 milligrams. So effectively, the patient would use 3 milligrams for any breakthrough pain, and they can use that up to 4 to 6 times daily. You would then monitor this over the next few days and use it to increase the dose of the long-acting twice daily morphine. Let's look at this in detail now. So let's say she's had 3 doses of the 3 milligrams over 24 hours in the past 3 days. So our total daily dose is 10 milligrams BD, that's 20, plus 3 of the 3 milligram dosage for breakthrough pain, that's 9 milligrams. So that gives a total of 29 milligrams over the last few days. So let's make it 30 milligrams for evenness. That would transfer into 15 milligrams twice daily, regular long-acting morphine. And then to calculate the new discretionary dose, it would be 1/6 of 30, which would be 5 milligrams. So this patient would receive 15 milligrams morning and 15 milligrams at night of the long-acting morphine, and then would have a discretionary dose of 5 milligrams for any breakthrough pain. And so gradually you would increase the dose here. There's no hurried or excessive increase in dose. This is all done very gradually, and it's much better tolerated like that, and much less harms for the patient through oversedation. Fentanyl should only be used for stable pain only. It's a very slow-acting drug and takes about 72 hours to reach steady state. And people should already be on a fairly steady dose of long-acting morphine equivalent to 60 milligrams total daily dose before they go on to transmucosal fentanyl. Adjuvants that are used range from gabapentin, pregabalin, tricyclic antidepressants, serotonin, noradrenaline reuptake inhibitors, sodium channel blockers like lignocaine patches, non-steroidals and cyclooxygenase inhibitors, and paracetamol itself. How most of these work is a mystery, but they do seem to modulate the pain and make it more bearable. Morphine sulfate should be regarded as the gold standard. It's been around a long time. There are no hidden secrets with it, and side effects can be well managed by the judicious use of co-prescribed antiemetics and laxatives in the majority of patients. It's very important that patients and carers are given information on recognizing oversedation or respiratory depression due to the excessive dose of morphine or equivalent. You should always have a very clear reason for changing the dose or the opioid or the route of administration. If in doubt, check calculations with a colleague. There may be other treatments of cancer pain as well, other than pain relief with morphine. For example, chemotherapy may be helpful, sometimes palliative radiotherapy, sometimes stenting if somebody has pain through difficulty swallowing for an esophageal cancer, for example, or surgery to stabilize bone nets in the lumbar spine or to relieve bowel obstruction. Chronic benign pain is different from pain related to a life-limiting condition. So that's not due to one of those. It's usually due to something else like osteoporosis, osteoarthritis, or musculoskeletal pain. Chronic benign pain is different in terms of the goals that we have for managing it are different. You should try to get a functional improvement in the patient. There should be a trial of medication with similar in line with the WHO pain ladder, but if there's no benefit, then they should be stopped. You should be careful to look out for adverse effects, for example, non-steroidal induced dyspepsia. There's very limited benefit of strong opioids, unlike in patients with cancer pain or other life-limiting illnesses. Focusing purely on the physical may not provide a solution to patients with overwhelming total pain. We need to have a more holistic view of this. So other things that can be used to ease pain would be physiotherapy through exercise therapy, electrotherapy, manual therapy, various aids and so on. Occupational therapy similarly might help patients to remain relatively more independent by managing their own activities of daily living. Pressure relieving cushions, mattresses, appropriate seating and so forth. Emotional support through a social worker, counseling, advice, advocacy, and spiritual support. These are all very important in supporting the patient, facilitating exploration of their concerns and so on. In patients with advanced lung disease like COPD or pulmonary fibrosis, breathlessness is a very common symptom. It also occurs in patients with heart failure and in a large number of cases with lung or other cancers. So the causes are multiple and may be associated with a variety of factors. Always look for a reversible cause like pleural effusion infection or heart failure. And even if the cancer is not curable, a palliative approach may be possible and in fact preferable. Be careful in prescribing oxygen, especially in patients with severe COPD, gold grade stage 3 or 4, because they depend on their hypoxemia in order to continue breathing. So in patients with type 2 respiratory failure, giving too much oxygen can actually be very harmful and even lethal. You may use low-dose opioids for breathlessness, but you need to be very careful titrating the dose very carefully. Sometimes anxiety can exacerbate breathlessness, and so occasionally low-dose benzodiazepines such as alprazolam may be useful. You also may use other approaches other than drugs, for example, cooling the air with a handheld fan, physiotherapy for the chest, and occupational therapy and attempts at relaxation therapy to minimize anxiety. Anorexia as a symptom is common, and it may arise due to the primary condition, and it may also be secondary to other things. For example, people on steroids may have mouth problems and oral thrush, may have nausea, constipation can also give rise to a poor appetite. Most experience of treating anorexia is in relation to anorexia related to cancer. It's always worth a trial of a drug like domperidone. Also dexamethasone may be helpful. And similarly migestrone. Nutritional supplements are generally not considered to be very effective. They don't seem to improve appetite very much. They're also quite expensive. You maybe need to explore the patient's and carers' feelings around anorexia, what it might mean for them. And you may need to explore the issue of normalizing not eating in their current state, especially at end of life. Nausea can be caused by a variety of by the primary cancer, if that's the underlying diagnosis, due to gastric stasis or intestinal obstruction. It could also be due to metabolic causes like hypercalcemia related to malignancy or failure such as renal failure, liver failure, or heart failure. And some drugs can also cause it. So can infection such as this supercurrent infection, chemotherapy or radiotherapy, brain mets. Pain itself can lead to nausea, and sometimes pain in association with anxiety or fear at end of life can also induce nausea. In general, reverse what is reversible, try to manage the cause of the nausea if possible using something like dexamethasone plus or minus radiotherapy. The drugs I mentioned before, domperidone, metoclopramide, are prokinetics. They act in two ways. One is locally acting on the stomach and delaying emptying, and the other one is a central effect on dopamine D2 receptor antagonists, much in the same way that antipsychotic drugs work. So just to be aware that some patients may develop jerking or stiffness or akathisia or dystonia as a result of adverse effect of domperidone and metoclopramide. There are also centrally acting drugs like cyclizine, haloperidol, levopromazine, and then there are 5-HT antagonists such as ondansetron. Again, practical advice would be to avoid exposure to foods that precipitate nausea. Give small snacks instead of large meals. Provide a calm, reassuring environment, and consider using acupressure wristbands if this may be effective. Constipation should be interpreted in the light of, especially in end-of-life care, reduced intake, altered intake, reduced mobility, the effects of medication, and possibly underlying obstruction if there's an underlying gastrointestinal cancer. Review medication that could be contributing to constipation, such as opioids, anticholinergics, or 5-HT antagonists like ondansetron. When prescribing opioids for pain in palliative care, they should always be prescribed with a laxative so that you don't get into this muddle of having to deal with constipation. Try to prevent it. You might want to consider a stool softener in addition to a stimulant laxative like senna. You should also discuss with the patient their preference. Some may not like some laxatives because they're quite syrupy or sugary, like lactulose, and they may prefer something like Movicol. They can try and see which they prefer. Consider fluid intake, fiber intake, and exercise, but options may be limited in the setting of a patient with a life-limiting condition, especially towards end of life. It's important as well to consider personal dignity when managing toileting. Rather than using a bedpan, if the patient prefers to use a toilet, see if this can be accommodated. A number of domains of professional competence in palliative care were covered in this lecture. Your task is to apply this knowledge and assess an appropriate patient with life-limiting illness while on the GB rotation. And then you will assess them using the following template. So this is the template used for your palliative care assignment, which you will present also in week 7, and you will also upload as part of your portfolio of assignments. So we put in age, gender, family situation, details of diagnosis, treatments to date, use generic names for drugs, look at current symptoms if there are some, and the current clinical findings and examination. Now, this examination may have been done by the palliative care physician or the nurse and not by yourself, but just annotate here what was found. Next, you look at a section on the patient's concerns and the patient's priorities. What do they want to do now that they're at their end of life? Have their priorities changed? What's their understanding of their diagnosis and of their prognosis? What are the concerns of their family or carers? Have there been ethical challenges that you have identified? What's your overall assessment? What will be your management plan? So this is what you would do, not what is being done currently. If you have any other ideas about how to do things differently, this is where you'd write it in. And then annotate here any learning need that you have identified and also how you address this. You present this in a PowerPoint presentation to the staff at Hospis Malaysia and faculty from the Department of Family Medicine in week 7. and you'll get formative feedback when the presentations have been complete. These are some references for you. Thank you very much for watching this video.